Cerebral toxoplasmosis. Toxoplasmosis is caused by Toxoplasma gondii, a tiny obligate intracellular protozoan measuring 2 to 5 micrometers. It can be identified in tissue samples by bright or Giemsa stain. In immunocompetent individuals, acute acquired infection is usually asymptomatic. After initial infection, parasite remains dormant in the body as tissue cyst. In immunocompromised patients, particularly HIV and AIDS, the reactivation of this latent cyst can occur, resulting in severe manifestations like encephalitis. Congenital toxoplasmosis develops when infection is transmitted transplacentally from infected mother to fetus during pregnancy, potentially causing serious neurological and ocular complications. Infective forms. Humans acquire infection with Toxoplasma gondii mainly through two infective forms. The first is tissue cysts containing bradyzoids, which are present in undercooked or raw meat, especially pork, lamb, and venison. Infection occurs when these cysts are ingested through consumption of inadequately cooked meat. The second infective form is sporulated oocyst containing sporozoites, which are shed in the feces of the infected cats. The cat is the definitive host of this parasite. Humans acquire infection by ingesting contaminated food or water or through contact with soil contaminated cat feces. Transmission may occur following organ transplantation, blood transfusion, bone marrow transplantation also, particularly when patient is immunocompromised. The risk of fatal transmission is highest during third trimester of pregnancy because placental transfer increases with gestational age. Here is the life cycle of Toxoplasma gondii. Cat is the definitive host in which a sexual phase of cycle is completed. Oocyst shed in the cat feces can infect a wide range of animals, including birds, rodents, grazing domestic animals, and humans. The bradyzoid found in the muzzle of the food animals may infect humans who eat insufficiently cooked meat products, particularly lamb and pork. Although human disease can take many forms, congenital infection and encephalitis from reactivation of latent infection in the brain of immunosuppressed person are the most important manifestations. Acquired toxoplasmosis. Toxoplasmosis acquired after birth is called acquired or postnatal toxoplasmosis. Infection commonly occurs from ingested raw undercooked meat containing tissue cyst. Another important source of infection is contact with the cat feces. Humans may also acquire infection through consumption of contaminated food and water. In patients with HIV, exact source of exposure is not often obvious because disease commonly results from reactivation of latent infection rather than new acquired infection. Congenital toxoplasmosis occurs when a pregnant woman develops primary infection with the toxoplasma, leading to maternal parasitemia and transplacental transmission. The risk of fetal infection is mainly associated with initial maternal infection acquired during pregnancy, particularly when mother has no prior immunity. Once a woman has infected and adequately treated, the risk of transmission in future pregnancies will become minimal. Pathogenesis. Toxoplasma gondii enters the body, invades the intestinal epithelium after ingestion of infective cyst. Within host, the parasite transforms rapidly, multiplying into tachyzoids which disseminate through bloodstream and lymphatics into various organs like CNS, retina, skeletal muscle, placenta, myocardium. Tissue damage can occur due to intracellular multiplication of the parasite, leading to cell destruction, focal necrosis, inflammatory reactions. As host immunity develops, the organism converts into bradyzoid and forms tissue cysts that persist lifelong. The immunocompromised individual, especially HIV and AIDS, these dormant bradyzoids can reactivate and convert back to tachyzoids, causing severe and potentially life-threatening diseases like encephalitis. In immunocompetent individuals, toxoplasma is usually asymptomatic or often remains unnoticed. When symptoms occur, the most clinical manifestation is cervical lymphadenopathy, which may persist for several weeks. Patient can also present with mild constitutional symptoms. Severe manifestations are uncommon in immunocompetent host. Immunocompromised patient, especially AIDS, it's an important opportunistic infection seen in patient with CD4 less than 100. Major manifestations which primarily affect the central nervous system. Patient commonly present with altered mental status, fever, headache, seizures, focal neurological deficits. Other neurological manifestations include aphasia, cranial nerve palsies, and ataxia. Most commonly involved areas in the brain are basal ganglia, brainstem, and corticomedullary junction. Congenital toxoplasmosis may present at birth with fever, rash, seizure, hepatosplenomegaly. Classical manifestations include chorioretinitis, hydrocephalus, microcephaly, intracranial calcifications, psychomotor retardation. Disease course is variable, with some infants presenting at birth while others manifest a month or years later. Chorioretinitis may appear late in the course of illness also. Many affected infants may die. Survivors will have persistent neurological deficit. It is classically characterized by a triad of chorioretinitis, hydrocephalus, intracranial calcifications. Other important clinical features include microcephaly, seizures, intellectual disability, psychomotor retardation, strabismus. Ocular toxoplasmosis is most common cause of posterior uveitis. Typically presents with blurred vision, scotoma, photophobia, and eye pain. Ophthalmoscopic examination shows yellow-white retinal lesions with retinochoroiditis. Diagnosis: IgG antibodies usually appear in 2 to 3 weeks of infection and persist for lifelong, indicating the past exposure. IgM antibodies suggest recent infection, although they may persist for a year or more. IgA antibodies are particularly useful in diagnosing congenital toxoplasmosis. Molecular diagnosis of toxoplasmosis is performed using PCR for detection of Toxoplasma DNA, particularly in CSF, amniotic fluid, and ocular fluid samples. Neuroimaging with CT or MRI of the brain typically shows multiple ring-enhancing lesions within the basal ganglia being the most common site of involvement. CSF usually reveals mild lymphocytic pleocytosis and increased protein levels, while glucose levels are generally normal. Toxoplasma encephalitis should be suspected in a HIV positive patient with CD4 count below 100 who presents with ring enhancing lesions. Confirmation is usually based on clinical and radiological improvement with anti-toxoplasma therapy. Definitive diagnosis is established by brain biopsy, which is reserved for patients who fail to respond after 2 weeks of empirical therapy. Diagnosis of toxoplasmosis in immunocompetent patient is mainly based on serology, including elevated or rising IgG antibody titers and a positive IgM fluorescent antibody test indicating recent infection. In HIV positive or other immunocompromised patient, antibody response may be absent, therefore diagnosis is often made clinically with supportive neuroimaging findings. In many cases, empirical treatment is started before confirmation. Lack of response to the therapy should prompt evaluation of primary CNS lymphoma or other intracranial mass lesions. Imaging: neuroimaging in toxoplasmosis typically shows ring enhancing lesions on CT or MRI of the brain, which may be single or multiple. CT or MRI of the brain in toxoplasmosis typically demonstrates multiple ring enhancing lesions with predilection of basal ganglia. Surrounding cerebral edema is commonly present. Important differential diagnoses to be considered are primary CNS lymphoma, progressive multifocal leukoencephalopathy, cryptococcosis, herpes simplex virus encephalitis. Here we can see cerebral toxoplasmosis in AIDS patient. First image, post-gadolinium axial and coronal. Second image, T1 weighted magnetic resonance imaging showing multiple ring enhancing lesion with the mass effect. In this image, we can see MRI showing rim enhancing toxoplasma abscess in the deep left cerebral hemisphere in patient with HIV. There is a mass effect and surrounding edema, features which are variable. Here we can see Toxoplasma encephalitis in a 36-year-old male patient with AIDS. Multiple lesions are demonstrated by MRI scan. Treatment. Standard therapy for toxoplasmosis includes pyrimethamine with a 200 mg loading dose followed by 75 mg daily, combined with sulfadiazine 0.5 to 1.5 gram every 6 hourly. Folinic acid 10 mg per day is added to prevent bone marrow toxicity caused by pyrimethamine. In patient with sulfa allergy, the alternate regimen of clindamycin with pyrimethamine can be used. Long-term suppressive maintenance therapy is usually required. Maintenance therapy may be discontinued in patient receiving effective combination of antiretroviral therapy when CD4 count remains above 200 for more than 6 months duration. Treatment should be continued for a minimum of 6 weeks. Immune reconstitution inflammatory syndrome (IRIS) may occur after initiation of antiretroviral therapy, causing exaggerated inflammatory response around the parasite lesion. In immunocompetent patient, treatment is often not required, although severe disease or ocular involvement should be treated. Ocular toxoplasmosis is managed with pyrimethamine combined with sulfadiazine or clindamycin and prednisolone. Trimethoprim sulfamethoxazole can also be used as an alternative regimen. Prophylaxis. Primary prophylaxis against toxoplasmosis is indicated in HIV positive patient with a CD4 count below 100 who are positive for Toxoplasma IgG. Recommended prophylactic drug is trimethoprim sulfamethoxazole. Prophylaxis can be discontinued once CD4 count rises above 200 for a period of more than 3 months while on ART. Preventive measures include avoiding undercooked meat, raw shellfish, contaminated water, and exposure to cat litter or cat feces. Proper food safety practice such as washing fruits, vegetables thoroughly and cooking the meat adequately is important. Cat-related precautions include cleaning litter boxes daily, avoiding stray cats, and feeding cats cooked or commercial food only.